No, I'm, you know, the one where the guy, like, stopping everybody. Saying, don't, nobody can do it. Confirmed it, and I stood in the doorway and started memorizing all the way.
Welcome.
And I had to come back to the
Call to order.
Extremely so.
That will help. You need a gavel. I know. Deb's tired.
You need cookies.
You have cookies.
All right, before we get started, does everybody have a cookie? All right.
Do you have a cookie?
I do not have a cookie.
You have more power than all of us combined.
I do. I do. But the important thing here is that we always need to make sure that the people that are calling in realize what they're missing. And I think that's profoundly important. All right, welcome everybody. I'm glad you're all here. First thing I'd just like to do is we are going to take a couple of things out of order today because what I'd like to do is make sure that some of the guests that we have in the room can get back to the business that they normally would be conducting today instead of being here. So if it's all right with everybody, we will start with approval of minutes right after we discuss new business, which is the Town of Providence and Galway ALS upgrade. Mike, would you like to introduce that topic for us?
Dr. Duthauer is going to be being our representative today. Sorry. Okay.
That sounds fine. Dr. Duthauer.
And I'd just like to state so Rob knows that these are the best cookies that he's missing.
Excellent.
I second that.
Go back and get a second
So
one.
They are in the box there.
Previously had a volunteer
Get one of the
ambulance service.
Amazon drones to deliver them.
Providence previously had a volunteer ambulance service that basically was unable to support itself, and the town of Providence decided to apply for its own ambulance service certificate. And in doing so, that was issued by the Department of Health back in mid-October as a BLS agency. As part of that process, the plan was for them to contract with Galway Ambulance to provide all of the service. So just so everybody's on the same page, Providence isn't going to go out and buy an ambulance and stock it. It's all contracted with surrounding agencies, predominantly Galway. Galway has been responding to that territory for years through the mutual aid plan, as Providence Volunteer was not able to get calls covered most of the time. The change in the plan now is that instead of waiting the 10 minutes of mutual aid time, Galway Ambulance is the primary dispatch agency to the town of Providence and that area between Route 29 and Sacandaga Lake, for those of you who don't know where the town of Providence may be. So, the request we're bringing up now is to upgrade from a BLS to an ALS agency. And again, it's basically just using Galway Ambulance's contract and current ALS level, but because of the way everything is worded, New York State requires everybody to be on the same ALS page. So that's the summary. And his kids didn't like it.
No, I think his kids want cookies too.
So that's the summary. If anybody has any questions, and then if there's specifics that anybody would need to know.
I think what's important, Tim, are you here?
Yep.
Tim, is there anything regarding this application that is anything other than administrative? Because as everything that I've reviewed leads me to believe that this is just an administrative approval of an agency that is already operating at the advanced life support level to provide that level of care in another district to which they are now going to be contracted to provide care.
Correct.
Okay. May I have a motion? Dr. Vogel. Thank you. Seconded, Dr. Funk. All in favor? Oh, excuse me, we've got discussion from the Department of Health.
Right, you have to approve Galway, the city itself is the one that has to hold the ALS title. So Providence is the Muni CON declaration, correct?
So the official motion needs to be the
That
town of
Because
Providence.
that's whose license they're operating under.
Okay, so the
He's got
town
no
of
contract.
Providence may be licensed at the advanced life support level and may contract with whomever they choose
Correct,
to
and
provide
their
that
contract
ALS.
just needs to address that all ALS and narcotics will be supplied by X, Y, and Z.
Okay, thank you, Mary.
Thank you for clarifying.
Sorry about that.
Maybe we take that as a friendly amendment,
Absolutely.
Dr. Vogel? Excellent. In favor, Dr. Funk? Thank you. Any other commentary? All in favor? Any opposed? Providence, congratulations. You now have an ALS certificate.
Thank you.
All right, if we can take it from the top of the standard agenda now. First, has everybody had an opportunity to review the November minutes? And is there a motion for approval, please? Motion for approval?
Sure.
From Dr. Doynow, seconded from
Sure.
Dr. Bosco. All in favor? Excellent, thank you. Any opposed?
Group is lethargic.
Excellent. That's very, very, very lethargic. Excused people. First, Dr. Halpert, who directed Dr. Doynow to serve as his proxy. Dr. Mao. Dr. Miles, who is on the line. Dr. Ushkow, who may be joining us. We have a notification letter from Clifton Park Half Moon of 3 additional medical directors. That is going to be one crowded system of medical direction, but it sounds like some very specific additions, which sounds actually pretty exciting. Dr. Miles, Dr. Wood, and Dr. Janikis will be joining Dr. Hermansdorfer as your medical director. Thank you very much for that notification. And the notification, as I said, for Dr. Halpert. Let's start with the academic committee. Dr. Doynow.
Okay, and actually, there'll be a little discussion on this. There's a new iPhone app that's out there for the collaborative protocols. If anybody wants to obtain it, it's free at the App Store. You have the actual name of it, Mike. I don't recall what it was. If you want to-
New York State or NYS collaborative protocols will bring it up.
Very nice. For your older folks, as myself, glasses are mandatory if you're going to try and read it. Clifton Park wants to upgrade the special care transport as well as MFI and RSI. The doc should have received what they were planning to do. We're going to need to vote on that at some time or other at this meeting. A whole lot of EMT courses out there as well. There was a discussion on continuing pre-hospital hypothermia, which we'll also need to vote on. And Mike has some information if you folks have not yet read the articles, which he did send out to everybody.
You want to just stop there for a little discussion on that?
We certainly can.
That's probably a good idea. So, hopefully everybody had a chance to read the articles that we forwarded out. Basically, 2 articles that appeared last week, one in the New England Journal of Medicine, one in the Journal of the American Medical Association regarding therapeutic hypothermia. One that was fascinating for those of us completing the therapeutic hypothermia for ROSC case, which is that perhaps it's not 33 degrees Celsius that's important, it may be 36. It was a actually pretty rigorous trial. I believe it came out of Denmark, actually, looking at patients who were chilled to 33 versus patients who were chilled to 36 and outcomes. The outcomes were no different between the 2 groups. It was actually a very nicely written paper with an accompanying editorial written by Cliff Calloway from Pittsburgh, who basically said maybe it's keeping people from becoming hyperthermic that ends up leading to good results. I think that's actually something that we'll all be focusing on inside the hospitals as we look to see how we're going to continue to provide care for these patients. The nice thing is, all the way across the board, patients are doing better after they have a cardiac arrest than they used to. And it may be because we're paying attention and not letting them get febrile. Who knows? That has less pertinence to this body than the other paper, which came out of Washington. It was Graham Nichols and his group in Seattle that actually came up with an extremely interesting case where they looked at patients who received or did not receive pre-hospital induction of therapeutic hypothermia utilizing 2 liters of chilled saline. The patients who had 2 liters of chilled saline pre-hospitally had an increased rearrest rate. They had increased incidence of CHF, and they had no improvement in outcomes. This led to Rochester and their cardiology group already requesting, and that notification already going out pre-hospitally, that there was to be no more pre-hospital induction of therapeutic hypothermia in the Monroe-Livingston area. I think that this was enough that this was important enough that I sought out input from our cardiology groups, because I wanted to make sure to remain as collaborative as possible as part of this, rather than just the ER docs telling people how it was going to be. Well, none of them answered, so it's going to be us. All right. We sought input from the major cardiology groups. Did not receive any useful input, unfortunately. And what I'd like to do here is discuss, is this an important enough paper for us with good enough results for us to, at this point, issue an advisory saying no more pre-hospital induction of therapeutic hypothermia utilizing 2 liters of chilled saline. The thing we still don't know, that we hopefully will get more information about in January, is whether or not intra-arrest therapeutic hypothermia, which is being studied in the city of New York, makes any difference in patient outcome. And Dr. Fries has told us, yes, that's his real name. Dr. Fries has told us that he will be presenting that data at the Remac in January. My thought at this point would be not to issue anything right now, to wait and see what happens with Dr. Fries's report, and then to make plans to continue this discussion and make a decision on this in February. But I open it to the floor.
I think that's reasonable. I mean, the agencies have spent a fair amount of money to do this mandate, and rather just cut it off without all the data, I would say wait. 2 more months is not going to make much of a difference, and if we do decide to remove it, it's going to be really tough to get it back in there again. So, I would say wait for 2 months.
I have rarely seen any patient that has gotten a full 2 liters of chilled saline on the way in, by the way, regardless of where they're coming from, which is interesting. Sam?
I agree with Don. And I agree with you too. I've seen the chilled saline started. I think I've seen at least one case that full 2 liters have been in, but usually not the full 2 liters by the time we get them. But maybe just because of our location. You know, we're getting people, unless they're coming from the hill towns, we're getting people pretty quickly.
Good point. Deb?
Is anybody aware of any additional research that is ongoing to look at this issue further? Maybe space it out. Would 1 liter be better? Would a goal of 36 degrees as opposed to 33 degrees be better? What if we just externally cool them instead of giving saline, which gives you the volume issues?
I think the biggest question will be, what about the external cooling rather than the volume-related cooling? There wasn't a difference between 0 and 2 in terms of outcomes, so I'm not anticipating that there's going to be suddenly a push to do a study on 1. I would be very surprised by that. This is really a pretty large sample size that they had for this paper, and it was really pretty well written. So I don't think that anybody's going to go back and look at that question again in terms of giving fluid.
But what about external cooling alone without fluid?
Don't know whether or not that's going to be a part of it too, particularly now that the question is 33 helpful at all anyway, or is it 36? Because if it's 36, we probably have all those patients 36 already anyway, maybe even lower, most of them probably lower. So as long as we're not allowing them to get hyperthermic pre-hospitally, we're probably in better shape. Ken?
Is there any local data we can pull from?
We don't have any data that's consistent enough, unfortunately. While we attempted to gather the CARES data, and that data collection is ongoing, it hasn't been consistently validated, and we haven't been able to get consistent input from the outcomes side of that, to be able to really look and see. And in order to drill down to find out exactly who got 250 mLs of fluid versus 2 liters of fluid would be almost impossible. Almost impossible. Okay, so we'll make that an agenda item for February to come up with a firm decision at that point if the facts are all available and if everybody can take a look at the literature as well as they consider along the way. Okay, thank you. Anybody to add anything from across the cyberspace? Dr. Miles, Dr. McHugh?
Nothing new.
I think there was,
Nothing for me.
Okay, thank you.
well, the kids wanted to end there.
That's right, I think so. That's still pushing for a cookie.
I
All right,
think so.
Don, I interrupted you.
No, no problem. That was basically the agenda. We do need to talk about the Clifton Park issue.
Gotcha. I think the only other two things that I had was first, the academic committee, we discussed whether or not 500
Oh, yeah.
ml
Mike-
bags of normal saline would be okay for some units.
Right, I know we need to
The
bring it up.
discussion was
Yeah, that's fine.
ultimately fine. The academic committee basically didn't make a voted recommendation, but said that there wasn't any potential harm for units carrying 500 milliliter bags of saline instead of liter bags if it was in a specialty situation.
I don't think we need to vote on that, so it's not an issue.
Not changing the formulary though.
Right. I mean, the only other issue we talked about was 24 coverage in regions other than
Outside of.
outside of our region, and not following formulary outside of here, but that's not an issue really for us.
Good points. Good points. All right. Let's jump to Clifton Park. All right. As we jump around, we'll jump to Clifton Park really quickly here at the request of Dr. Miles. So, Joe, if you would like to introduce your program to the group.
Sure. What Clifton Park is proposing is a combined upgrade with both rapid sequence induction MFI program, which follows on the coattails of the Saratoga County Collaborative MFI program, and to fold that into a specialty care transport program for our organization. The MFI plan is fairly consistent with what we've seen in the region for training programs. We have added to it, in typical Clifton Park fashion, quite a bit of research and additional education material, pharmacology, specialty experts coming in and providing some of the hands-on education, those specialty folks being anesthesia, nurse anesthetist providers, to run the majority of our program. The MFI stuff aside, the specialty care transport, what we're interested in doing is we're asking for permission from the MAC to upgrade to a specialty care ability for select providers of the organization to better serve some of our health system partners who are located across the street from our station. We have had occasion where we've had one or two folks that require nursing to go with the patient, just because the scope of modality was outside of our ability to take that patient. At night, Ellis Medicine is minimally staffed with nursing, so it does strip their resources 50 to sometimes 100%. That's not good practice for them, that's not good practice for us. So what we're looking to do is allow those patients to go with our providers and leave those assets available to Ellis. So that being said, the packet that went out was a little bit of background about Clifton Park, just an overview of a business plan. Essentially what we're interested in doing is fairly consistent with specialty care transport programs at Greenport and with GAVAC. We did ask for class authorization of specific classes of medication rather than individual medications. It's just from a logistics perspective almost impossible to list specific medications. There is a caveat in here that we will accept blood or blood products that are already infusing, utilizing some of our dual-hatted nurse paramedic staff that are on. But again, that will be an as-needed deployment based on referent facility request and staff availability. It's not something that we're going to be able to staff 24 hours a day, but if there is an occasion that blood product need to be administered immediately, we do have the staff to be able to take that in the ambulance without stripping resources from the center. As far as modalities go, we're asking for the ability to take patients with mechanical ventilation, non-invasive positive pressure, both CPAP and BiPAP, and right now just chest tube thoracotomy with sealed drainage. Obviously, this is a working document, and as
Sealed drainage or water seal?
water seal. There is a very specific procedure that we will follow to make sure that these calls get screened. They'll get screened by a director. The calls will come into the shift supervisor. Shift supervisor will push all that patient information up to a director. The director will authorize the patient as long as they meet this inclusion criteria. If there's any question, direct medical direction will be established with one of now 4 medical directors, whoever's covering. If there is any discrepancy, any issue between the referring physician and our medical director, we ultimately get to a no transport scenario. And we have to start looking for other resources. Credentialing process for SCT for us is all pre-consideration qualifications is a minimum of 3 years ALS for paramedics. Completion of the American Association of Critical Care Nurses Essentials and Critical Care Orientation LMS online training program. That's a 69-hour critical care education program through the learning management system. In addition to that is another AACN critical care pharmacology program, which is another 40 hours of LMS. Completion of the MFI training program. Individually screened, interviewed, and approved by medical direction. And then board certification as critical care paramedic certified. In addition to that, we will require 2 medical attendants for every specialty care transport. And that's 2 credentialed medical attendants, not 1 credentialed, 1 paramedic. So the only, there is in the packet that went out is syllabus for the 2 online programs. And the only addition is a memorandum of exemption to training for 7 individuals who have already practiced at the critical care level pre-hospitally. 6 of those individuals are dual-hatted, 5 of those individuals are dual-hatted registered nurse paramedics already. Most of our experience all comes from LifeNet in New York. Essentially, this memorandum comes as a result of needing preceptors. If we don't have folks who are already credentialed to practice at the SCT level, who is going to train the up-and-comings? So that's what this memorandum is signed by Dr. Miles as an exemption to, not an exemption, but we will complete this training in parallel with everybody else, but we will be credentialed immediately to practice at the SCT level. And that's our SCT program in a nutshell. There are some financial considerations in the business plan, capital requirements and stuff in the beginning in the executive summary, which I'll answer any of those questions if anybody has questions.
What's the time frame of all your providers being FPC certified?
We have a go live hopefully by 1 May.
So to start, they're all going to be certified, or just the initial 7 that you talked about, and then the others will be getting certified?
The initial 7, everybody should be credentialed by 1 May.
It's an amazing, amazing statement, I think, to make for the region and for the state to recognize that as a credentialing for this level of care.
We're going to try.
Yeah, I congratulate you for it.
So, thank you.
Just with the exemption that Joe has put into the specialty care transport, we would like to actually start providing that service January 1 with these 7 exemptions that Dr. Miles has signed off on. And as Joe has stipulated, 5 of those are registered nurse paramedics. That I think all of us except 1 have worked for LifeNet, and the other one is a adult nurse practitioner specializing in critical care. So I don't think there's any issues with the 7 exemptions.
But we will all, even the exempted folks, meet that critical care paramedic certified by May.
Sounds like quite a program. Any other questions from anybody? Floor?
I have a question for
Yeah.
Deb Funk, because we work excessively with the pre-hospital blood issues. A freestanding, I mean, I'll pick on Joe. Joe's a freestanding nurse for all practical needs.
Absolutely. Free agent.
He's a nurse. The law requires a nurse.
He's a nurse.
So that's, you know this better than anyone, just because of all of your efforts.
Joe's job is to figure out who's going to insure him to do it. But I think according to the law, as long as there's a person on that list, nurse is one of those people, paramedic is not, then I don't know that the blood and tissue people would have a problem with, you know,
He
any
would be
nurse
the
doing this
resident
in a part
expert
of the
on
job.
We're lucky in that we are working collaboratively with Ellis Medicine as the only sending facility. And we are taking all of their self-learning modules and policies and procedures for blood product administration, and we're echoing those in our program so that there is no difference between our administration, blood product administration policies and procedures than there is at Ellis Medicine.
And you're not going to be independently transfusing them. You're going to be transporting them with blood that's hanging already from in this patient.
I
think
wouldn't
it's-
limit yourself to blood that's already hanging. You know, what if you want to dump as much FFP into the person whose INR is 9 and actively bleeding? You should be able to give blood that's been ordered by the sending physician, right? I wouldn't narrow yourself into something within the list.
Good advice.
I mean, Deb, you would know better than us, but we've researched this to the best of our abilities, and we really see nothing that would prevent us from having a freestanding registered nurse do that. And not really, I know when MedFlight first started, I was involved in that, but we were hospital employees. And then obviously when I went to Rocky Mountain and so forth, you really weren't affiliated with the hospital any longer, kind of freestanding. So I don't think our model's not much different than what LifeNet really is. We're not looking to do anything that much differently.
I think that the only issue is you will be acting as a nurse, and so all of a sudden your nursing license is on the line. So insurance-wise, what if there's a bad outcome? Will Clifton Park's insurance policy cover you since you were acting as a nurse, and that's not your job there? So I think that is the only issue. I think according to the law, all you need is to have a nursing license.
No, I think, Deb, actually it's different than that, because it is their job there, right? And that's what Joe is saying.
Yeah.
It is
We're
going to be
job
his job
description
there.
as such.
So what you need to do is make sure that that insurance company is ready to step
Make sure that the
up.
insurance company knows that that's happening so that they can't say that
Right.
they're blindsided by it.
And this is
I like it.
very specifically written in accordance with the Nurse Practice Act.
Yeah.
Which, nurses working outside the hospital, they walk a fine line with the Nurse Practice Act and not having patient-specific orders and patient-specific orders to titrate.
Well, it's a protocol. It's like an order.
It's pretty, yes, I agree. But what I want to do is I do want to protect the licenses of the nurses, so this is written in that way.
I would have to agree that, based on the Nurse Practice Act, that you almost took certain paragraphs word for word to make sure that you didn't violate that.
Indeed, I did.
Yeah, it looked very, very familiar.
And it's important to note that it's not plagiarism if it's in the public domain.
Right.
Any other thoughts or commentary? I think at this point you have brought it to us. We have certainly heard a nice presentation and read some really good-looking plans. We have a motion for approval for Clifton Park to move forward with this.
I'll make a motion.
Dr. Doyle, second from Dr. Font. All in favor?
Aye.
Excellent.
Thank you.
There's a wave back there too. Just
There's way back there too. Thank you, Dr. McHugh. My apologies for missing.
This is one of these nurses.
All right. Where are we? CMAC coming up in January, the week of NAMSP, we might add. It's also the week of Don's anniversary, so Don will be away that. SEMSCO as well. Next meeting of the HOC is on the 18th. No EPI upgrades. We have discussed the town of Providence. PAD apps, multiple PAD applications, including one listed as an original that actually already existed. So we'll go back and deal with that and figure out why it's an original instead of not. But nice to see more PAD applications out there. Hopefully someday PAD will move into a position where we're going to be able to have a good registry, be able to get good information back to the people who actually have the PAD devices themselves, and it won't require us to waste the ink on them, because I'm not sure it adds anything to bringing them here. Couple of pieces of new business. First is inter-regional communication process for providers being taken offline. And I saw Mr. Hannigan here. Did Mr. Hannigan disappear? Good. I'm glad you're here.
Thank you.
You're not here for this, but your help here may be important. So there was some question about people that are taken offline in one region, then appearing in the next region and starting to practice. This is different than someone who loses the ability to practice with a New York State certification, which would be a notification that comes from the Department of Health. It would be something that really is pertinent to individual medical advisory committees and our responsibility under the regulations to make sure that we're looking out for the people within our region. How do we effectively let regions around us know when we take somebody offline? Can we? And should we?
Those are all excellent questions, Dr. Daly. Other than giving you a wild-ass guess of a response right now,
Noted as such, sir.
if it's not for a disciplinary matter, then I think you need to be, I think I would be very circumspect in sending out a notification if it was something other than just a, here's a roster who's active and who's not, because you could be, I think you might be, you could potentially be interfering with someone's ability to earn a living and their right to practice if it's something other than a disciplinary matter. Now, I guess without having a particular circumstance, a particular individual, is it somebody just opts not to maintain their...
Let's say someone has been an ongoing quality concern within the region. Dr. Bosco, for example, is practicing as a paramedic. And he pushes IV epi for the second time and causes someone to have a heart attack.
It's after I gave the IV potassium push.
After he did the IV potassium, which wasn't on the formulary in the first place. Then we take him offline in the region. Should we notify the other regions around us? Or if we take someone offline in the region, do we just automatically have to bump it straight up to the state?
If you're taking them off for cause, then you have to look at what's your obligation with the state. If you're taking them off because some paramedics, all paramedics are equal, but some of them aren't as good as others, and you're taking them off because of a history or propensity, but nothing that's really actionable, then I think you got to be very careful and very selective. I don't know that you can send out an email blast that says we don't like this guy, or we've had enough, but he hasn't really done anything, to draw the state's eye. I think, let me throw it right back at you. Suppose it's not a paramedic, suppose it's a doctor. Who, for whatever reason, loses his or her privileges at a hospital. Is it incumbent upon that employer, if you will use the term employer, to, or is it legal for that employer to notify that individual's other employers or other institutions where that physician has privileges of the leg? I don't believe there's a legal basis for you to do it unless it was something other than a roster. Here's a list of all of our paramedics. Somebody's not on there to follow the money. But I am making this up.
Yeah, no, and I appreciate it.
I think the way that this gets handled, I know at least from the physician side, when you apply for privileges at a hospital, and we have to redo it as we reapply for privileges. There's a question on the application that says, have you lost your privileges or your license in any other state or in any other institution? And you then answer that. We don't do that in EMS, but maybe we either should, or we should rely, or we should always check references. Not just those references that the provider gives you, but call their last place of employment to find out if they have any ongoing QA issues. And if you're not checking references before you hire somebody, shame on you. You probably deserve to get a paramedic who's been taken off.
Beth and Sam.
As an employer, we routinely ask for releases to check with previous employers and tell us what previous regions you have been credentialed in. That works for the new hire. It does not work for the already credentialed provider who gets in trouble someplace else.
That's because we don't renew our
We don't
privileges.
re-credential people.
You know, maybe that's something we need to look at, is renewing our privileges within the system.
Sam?
With the state,
Well,
but not with your agency.
I think our obligation is twofold. One, if it's raised to a level of concern that it's reportable to the state, then we need to report it to the state. Secondly, if the agency or this body is approached by someone outside the region, then I guess I would defer to legal about what information can be shared at that point. Because if without a release of information from the applicant, you could also run into trouble there. So I think that all you can say is the person was credentialed here from time A to time B, unless there's a release of information that's going to allow you to talk about that person. So that's what I see our responsibilities are. You know.
What about the person that's working in two regions at the same time? And in one region, they've been taken offline. Do you have that responsibility to tell the other region? Because they're still working.
Do you know that
Even
they're
if there's
working in the other
protocol
region?
Yes.
protocols, though.
We're such a mobile society, and I've had providers that have been credentialed in 4 regions.
It's a good,
And we use the
good
same
question.
protocol.
In all honesty, that's no different than a physician working at Albany Memorial and Glens Falls at the same time.
Right, but the way that gets caught is in the credentialing cycle, and what we're saying here is that's not caught in the re-credentialing cycle of the medics.
Right. I think the issue is exactly that, not so much notification, it's a re-credentialing cycle.
And maybe that's what we need to look at, is how do we re-credential the medics, and do we need a little bit of a stricter reapplication that asks some of the questions that we all get asked as physicians? Because then if you find someone is dishonest in that application, you can summarily dismiss them. And you don't have to go through.
So what do you do during that remediation period?
Dr. Gill.
Well, I think that's the
that I do with them.
quality improvement plan that you got to put in place if you think that individual is salvageable. You know.
No, I mean with regards to the other region of the practice.
I think maybe the solution might be somewhere on the receiving end. If someone's practicing in our region and has their privileges affected in another region, the answer may be, in terms of our credentialing on the front end, that you have to keep us advised of any change in your status in any region. Make it an ongoing obligation.
That's an excellent.
As far as the obligation of the reps go, and again, bear in mind, complete disclaimer, I am making this up as I'm standing here.
Disclaimer duly noted, sir.
I don't, note it again, a couple, 3 times.
Re-noted.
I'm really kind of grasping as to what we should be doing affirmatively if we're, because we could be interfering with someone's employment opportunity for reasons that, that don't warrant the state's attention. It could be a personality, and it could be a host of different reasons. And I would be concerned from our standpoint affirmatively going out and broadcasting. But admittedly, I haven't really looked into it. I see the moral a moral obligation or perhaps a moral concern. But I think that, no, I'll defer to that.
Rich, you've been looking concerned back there for a little while.
Just a personal observation from my own experience, I have found that many employers today have opted to limit their response to reference inquiries, confirming dates of employment, position or positions held. They probably have a reason for that. And many have probably done so on the advice of their counsel.
Yep.
I've also heard when I've called places to check references, all I get is whether they are eligible for rehire or not. And that's also just a very simple, not sharing anything with you. However, if
Sam?
One of the concerns that I have about, reporting things to other regions and that kind of thing is a lot of issues are personnel issues and not necessarily quality of care issues.
Personnel and personality.
Exactly. And I think you really tread a fine line when, if you're trying, I don't think we're doing a service to anybody by sharing information, nor should agencies share information about personnel action issues. So, I mean, that's another concern with all of this.
there are also very different levels of tolerance between agencies.
Yes.
You may choose to pull somebody offline because you don't like the way they practice. I may be fine with them practicing that way. I find that there's a lot of different levels.
I think the other thing you have to consider is some regions are farther advanced than others. Like, I've been a paramedic for 30 years, and the Remac region has been farther advanced than the Mountain Lakes region for many years. And I've been known to piss off a physician or two in the Mountain Lakes region. So if the Mountain Lakes region was to take action against me, should that impact my ability to work in the Remac region?
Mm-hmm. He said yes.
I will.
Along those
For the record, that was thoughtful commentary, Mr. Baring. Dean.
Right now, what's in place is when a new provider comes to become credentialed in the region, we require them to, and they tell us that they were online in another region, we require that other region to send us some kind of a letter or email saying that there is no open QI issues or investigations. And they require the same. So that's pre-credentialing. Once they're credentialed, there's no catching.
Interesting times.
Well, I would think it, rather than us getting into this mode of talking to other regions, if it's that grievous, you send it to the state, and then the state decides whether they should continue as a medic. If the state decides that they have no reason to pull their certificate, then I think that's...
Remember, that from time to time has turned into this circular situation that we've ended up in the middle of, so that becomes difficult too.
The other thing that we discussed a number of years ago, and we seem to come back to, and here we are again, was a point that Deb kind of brought up, which is when a paramedic practices, who allows, what physician specifically or what body allows them to practice. If I'm one of Dr. Funk's paramedics, I'm one of Dr. Funk's paramedics. Am I also responsible to a region to remove me, or is it Dr. Funk that allows me to provide care? Is it agency specific or regionally specific?
I think actually that's one of those things that in the regs, while you can put them on, the region ultimately is responsible for credentialing those paramedics. So our process is on a regional basis, but Terry
Rich would know best.
Or Rich, from my memory, it's one of the regional responsibilities is credentialing their advanced providers.
I don't know if it's necessarily in that wording though. Rich, what's the
But I have to
what's
sign
the
on for an
deliverable for the
individual
region
paramedic.
as far
That's
as
a regulation
ALS
change, we mandated we have to have a medical director.
Yeah, I
Right.
agree with the responsibility. Mary, I'll defer to you. You're the expert in public health law.
Keep passing it.
I think the responsibility on this lies in the agency medical director.
I agree.
The Remac in statute is charged with creating protocols and
Standards.
standards. But I don't know if they're responsible for individual providers in an agency.
I believe we have an answer to this in the office because we're dealing with it with a different region.
Okay.
I'm just trying to make sure that I have the correct interpretation.
Gotcha.
They issued a medical, that's what they decided.
No, that was a different issue, and that one was decided, what he's bringing up is Mountain Lakes, they're equivalent to Tim, several Tims ago. Basically, no, it wasn't one of the jail time either. Basically, what he did is he took it upon himself as the executive director to send out an email saying, you know, John Doe is a bad paramedic, do not hire her. And that was ruled as a no-go. I'm trying to get Dan Clayton to confirm. My latest interpretation of this is if you, as the Remac chair, notified your counterpart, say Gus Leinhardt, as the Remac chair of ARMS, in the interest of QI, this person practices in both regions. My understanding is that is the acceptable way to do it, but only under that framework. So if you know that they're practicing in another region. But I'm trying to get, Dan was talking about this yesterday and today, and he hasn't confirmed that, but I'm 95% sure that that is the correct way to do it, but I just want.
I think I'd like to get that last 5% certain, as well as
Exactly.
Mr. Hannigan to stop rocking back and forth before
I know, but that's why I'm
make any phone
clarifying it
calls.
as such.
Yeah, no, thank you.
That would be a great place to hide under 3006, but I don't know that, as I read that literally, it is that expansive. But it's a good place.
That was the latest thought in the office because of an issue involving one individual practicing in 3 different regions.
Well, what's our goal here, Dr. Daly?
This actually was just an item for discussion, and I think discussion we certainly have had. Frankly, the most important thing here is in 3006, it certainly provides an interesting place for something we have concerns for an ongoing quality issue and for expanding a quality assurance investigation as well. And maybe that is one of the ways to do that. And that actually would fall under the interesting protections, but I would certainly want to increase the knowledge base that we have on that before anything moves forward from there. Jeff?
Should that be an interesting question to add to our turnaround document? Have you had your privileges revoked in another region or other agency in the region?
The notes that I made for myself here, Jeff, was whether or not we should have a release of information from other regions and employers as part of that re-credentialing document, and whether or not there should be an ongoing obligation to our providers to notify the region and their employers of any changes in status across that.
Right off the bat, they have to do it at least once a year.
Right. And that's probably not an unreasonable way to do it. Ultimately, does this, it puts the onus on the individuals, but I think it at least creates the expectation that there will be conversation. And hopefully we just never have a problem. What?
Do we have the legal right to ask that?
Sure. So from here, we'll see how we can explore that. Dean, Tim, can we work on that for the re-credentialing document? I think we would be hard pressed to do that still for 14, but we should look at how we can do that for 15.
Because the question is, how do you enforce it if they are not truthful?
I think like so many other things, everything that we do is self-reported in EMS. What goes on in the back of an ambulance and what goes on when they're out of view will always be self-reported. In this case, I don't think this is something we're going to be able to do any more than an enforcement if it appears.
It was my understanding that last time we revisited turnaround documents, though, before Deb leaves, I see her shouldering up there, that medical directors and ALS coordinators are who's verifying that somebody is still online with an agency, and they're simply reporting that back to the region. So then how do we regionally say that we're going to require something?
We'll allow Dean and Tim to come up with a creative way to have each of the people do that. And it may end up being that we come up with a form that they sign that then gets turned into their agency themselves.
Right.
Okay.
Mike, how many ALS providers do we have in the region that we're responsible for?
900. Is it 900? I thought it was in the high sevens. 9.
That's a lot in terms of the management of this.
Right.
Dan confirmed that is the correct.
I don't know how we're going to do that.
I got it. I just need a number.
Mike, Dan confirmed that is correct, my interpretation. Dan Clayton just.
Regional medical director or regional medical director.
In the interest of QI.
In the interest
can
of
be done.
QI, have a
Correct.
conversation about a specific investigation.
That is correct.
Okay, that'd be a specific investigation.
Yes.
All right, to keep going, Dr. Flunk is leaving us. I don't think we have any, we do not have any more items for votes, which is good. Item of notification for everybody. The Remo originated naloxone program for BLS providers has been approved by the Commissioner of Health, and all levels of EMS providers in New York State will be able to administer intranasal naloxone for opioid overdose.
Just intranasal.
What?
Just intranasal.
Just intranasal, exactly. What?
Including CFR.
Including CFRs and EMRs, exactly.
Effective?
Effective? Whenever they can get it on the website, I suspect. Not on there yet. I checked. But since I just got the notification 2 hours ago, I'm not really surprised it's not there yet. We have a group of people that's going to come together to assist in the review of some changes to the protocols for 2015. If you're interested in being part of that small, tight group, before it comes forth as a single document, please come up, put your information on this yellow piece of paper. Okay? Goal is small, tight group. Okay? And the only other thing was an interesting question that came from the folks at Clifton Park, who've been having a problem with their electronic documentation not being uploaded appropriately into the state data set, because unfortunately they don't always have 2 blood pressures or even 1 blood pressure on some of their patients. They've had mental health patients who've refused blood pressures. They've had pediatric patients who they haven't wanted to agitate and get blood pressures on. And they've had patients that have left before they get a second blood pressure. The patient, those medical records are not being uploaded and accepted into the state system. Unfortunately, these sound like very medically appropriate situations to not obtain a blood pressure. We don't get blood pressures at Albany Med on our 2-year-olds. Because unless they've got cardiac problems, they probably don't need a blood pressure. All right? And if there's going to be a mental health tussle in the back of an ambulance over a blood pressure, let's not get a blood pressure. That's the right thing for our folks to do. Let's protect ourselves. Right? So that's just going to be an ongoing thing that I may need some help with as we move forward. We'll see what happens. Dan?
I don't know what documentation software they are using. We're old products, obviously, and we routinely upload vitals that are incomplete, and they can be accepted. You get a bad score against them. You obviously get deducted for your validation score, but they still get uploaded. So my first thought process is they have something set up wrong in the mapping or whatever. And
we're working with EMS charts,
Okay.
and with the recent changes that they negotiated with New York State, that's when this all occurred.
Because it's a 3-step process. It's a, does it go from us to them? Does it get pigeonholed into the right data set? And does it get measured against the validation? There's 3 different steps. And my validation has really sucked recently because we just started. But they're accepting everything. It's just that I'm not meeting their
But you're also a
documentation.
whole product. This could be a specific EMS charts.
Right. I'm on image trend.
Now, we use EMS charts in Albany County, and I'm finding myself that I'm running into issues when I'm clearing charts as a supervisor.
Yeah.
That you'll get the NEMSIS warning on it, and you have to choose to basically bypass it and continue to go. I don't know administrator level whether the stuff's being uploaded or not, or you're just saying, hey,
Yeah,
it's
that's
not
the
going.
problem that they were highlighting is that they bypass it at the administrator level or at the supervisor level, and then it gets bounced back to the administrator level. So it sounds like this may be a software-specific thing for them to continue to work with, stay with. Keep us posted. Yeah. Keep us posted, because it sounds like medically appropriate cases. Right. So, all right.
It's just, beware that the problem is not going away soon. It grows daily as we continue to work on it.
Gotcha. Thank you. All right. Anybody else have any pending business? If not, we will adjourn to executive session. Dan, your hand's not up high enough.
I threw you an email, and I'd like to bring a topic to the physicians here.
Oh, please.
To start conversation on, not specifically looking for a resolution. I don't think I can get a resolution today. I participate in a coalition called Schenectady Coalition for a Healthier Community. And the coalition is about a year old. It is built out of about 25 agencies, companies, etc., that have come together to look at healthcare issues in Schenectady County and try to deliver a better health product to Schenectady County. We just a short bit ago finished a You Matter survey. 2,000 residents of Schenectady City were surveyed to determine where health needs were. And we discovered Schenectady isn't very healthy at all. And there are 12 tasks.
I'm sorry it took you a survey to figure that out, Tim.
Yeah. We have 12 different tasks or points that we have, action plans that we're coming out of the survey with. One of the action plans, one of the things we identified is 1 out of 3 residents in Schenectady visit an ED at least once in a calendar year. And so one of the identifications is that our ED is being very inappropriately used. And to take a look at seeing if there's a way that EMS, through a medical oversight process, can go out and triage EMS patients and determine a better place to take them for care. What we're looking at, we have submitted a letter of intent to PCORI, PCORI, which is the Patient Center Organization, Patient Centers Outcome Research Institute, for a grant to study whether we can build algorithms to assess patients under medical oversight and take subacute patients to subacute care centers, such as an urgent care center. So we are in the process of writing the grant application, and we're going to have to obviously talk to several different bodies, governing bodies, about this issue. But this is one governing body which about 15 years ago placed a directive out there that the ambulances in this remote region could not transport emergency patients to anything but an Article 28 ED facility. So that's
a state, not a region.
Well, this region and also the patients in Schenectady, the volume that you're looking at that are using the ED inappropriately, they're not going to be accepted in urgent care that's a cash or insured only. Problem is you're not going to have a destination to take them to.
But what about community paramedics, which is starting to become a trend elsewhere?
The Article 30 changes this.
Well, no, because we've got some different things, right? The idea behind a lot of community paramedicine is preventing readmission.
And preventing them from coming in.
Right? But what Dan's talking about is taking basically a whole lot of low-hanging fruit and getting it somewhere else.
Right.
There are a whole lot of problems associated with that. And I think the first step that's interesting is this body saying that emergency patients can only go to emergency departments. That actually was before I sat with this group.
Right.
I'm sure there were some very interesting discussions here. And frankly, I think this sounds like an exciting idea, and I'd like to see how it ends up playing out. From that, though, I also was sitting at the CMAC when Monroe Livingston came in with their plan, which was exactly what you're describing right now, which was let's get buy-in from our urgent care centers so that we can then transport patients directly to the urgent care centers. If we bring them there, the urgent care center, regardless of their ability to pay, will provide care for that person. There was a subset of their providers that were trained specifically in how to evaluate these patients. There were a subset of physicians that were authorized to take the medical control calls around these. There were approximately, and my numbers are off, but the scope is not off. There were somewhere in the neighborhood of 10,000 potential calls that they went on, of which I think they were able to triage less than 100, and well less than 100, to any urgent care center because of all of the stipulations that were put on the provision of care this way. So I guess I would just give you pause, but at the same time, build something that's strong, build something with good oversight, and hopefully we can see whether or not we can get something to work. Beth?
Just attended a webinar in which, as you said, a lot of the mobile integrated healthcare stuff is preventing readmissions. There's one agency, and I could go back to the webinar, that actually, and it might be Fort Worth, Texas, puts a nurse in the PSAP. Is it Fort Worth, Texas? That puts a nurse in the PSAP to take these non-emergent 911 calls, triage them, and either send them back out to the ambulance if it's appropriate, or to that lower level of care. Let's get you a cab, let's get you a taxi, let's get you, something to get you to the appropriate level of care.
I think
That's a front end approach.
I think there are a lot of different potential answers. I think the goal of building something here that could do this is huge, absolutely huge. I would ask, the first thing that I would ask would be, if you are going to do this, make sure that heading in the door and starting out on this, that it is IRB approved, so this can end up getting written up and written up appropriately.
It is. Ellis is the Ellis Hospital.
Oh, good.
They have a branch, a group out of Ellis Hospital that is doing this.
Good.
Dr. David Pratt is the one who's writing the grant, involved in writing the grant, and this is going for IRB.
Good,
So
good.
we have
Excellent.
a lot of hurdles to clear,
Excellent.
and this is just in the beginning of it. But we obviously have several agencies we need to discuss this with. It's actually going to be a three-phase study. First phase is going to be retrospectively looking at 300 cases to try to come up with a triage algorithm that EMS and physicians can use to identify this lower hanging fruit. The second phase is to prospectively take a look at 600 transports that happened and take a look at the charting from EMS and follow up with the charting from the ED, follow them through the algorithm to say, yes, we could have diverted this, and then take a look at their follow-up charting to say, would there have been any negative outcome if we did indeed do this? And then the third phase, which wasn't in the original letter of intent, but came up as we really should probably go down this road if we're going to do this seriously, would be what they're looking to do is what we're looking for is a waiver to trial 300 patients, where we would have an algorithm to follow, physician consult in order to divert the patient, and then this group would do a follow-up survey of the patient to make sure the patient felt satisfied, they felt they were happy with the care they got, and they felt they got the right care, as well as a medical chart review to make sure that there were no bad outcomes or adverse outcomes.
Sounds interesting. Sam?
Well, first of all, I have no objection to us granting, a project of this to occur in the region, but I do want to make a couple comments. First of all, other parts of the country have been looking at this. Secondly, the third-party payers with Obamacare and utilization and everything are very interested in this. Some of the utilization committees in the third-party payers in this region would be very interested in this. So I don't think this is something that is just going to, wither away. I think we'll hear more about this. But thirdly, I also want to comment that, retrospective data about necessary ED visits is fraught with a lot of problems. And depending on the mindset and perspective of the author of those studies, they range anywhere from 8% to 85% of ED visits are quote-unquote unnecessary. And when you look at retrospective studies, they're all way too high because the horse is out the door and you know that the patient is safe. But you didn't know that beforehand. So retrospective studies, A, are very difficult. Secondly, the accepted, if you will, from an emergency medicine perspective, range is really dependent upon the type of practice you're in, where the emergency department is, the number of uninsured, et cetera. But it can range anywhere from like 8 to 17, 18% of visits that are truly not necessary in the ED. So the great majority of visits appear to be necessary. So the goal in a program like this shouldn't be to divert, 40, 50% of your calls in a region like Albany and the outlying areas. If you were to divert 1 in 7, 1 in 8 patients, I think it would be a big success.
Yeah.
But I'm just saying, you got to be careful with this. I mean, I just.
No, I know, I understand. The retrospective study part of it was to help to look at patients and build an algorithm, not to actually determine whether they should have been diverted or not, but to help to identify which patients could qualify for redirection. And then once we had the algorithms built with oversight, then we would actually run 600 calls that we are currently doing through the system to see if they would have fallen out or if there would have been any bad outcome. And then lastly would be to actually trial it. The action plan is actually looking for a 5% reduction. That's our target in the action
I think
plan.
that's appropriate, and you have to approach it from a prospective complaint presentation perspective.
Right.
That's the issue, Yeah, the chest pain may turn out to have been indigestion, but you don't know that you know that retrospectively, not prospectively. I don't even know that you know that retrospectively without keeping the patient 24 hours. But the point I'm making is that's the example that's always used. You know what I mean?
It'll be interesting to see how this gets
Right.
built, and I'd like to see it before we say, go forth and start it. I'd like to see a more concrete presentation of this to all of us. But frankly, at this point, I'm more than willing to make the motion from the chair to say that this sounds like a great idea. Let's see whether or not we can make it work.
Mm-hmm.
Dr. Dale, Dr. McHugh.
Dr. McHugh, please.
I think 5% if that's your target, being on the receiving end in Schenectady, we probably could do that. I mean, McClellan's body as a whole, most of them have no need to see a physician at all in the next week.
Just a little history from EMS dark ages back here. From what I recall, why this body ended up saying that people had to go directly to the ED. There was a case somewhere in the early 90s. If you guys remember, there used to be a CHP, used to be one of the health plans.
Yes.
And they were very specific about trying to keep their patients seeing their docs first before going to the EDs. And the docs really got penalized if they sent patients in, which is hard to believe nowadays when that seems to be all that happens. But the bottom line is somebody demanded being transported with chest pain to one of their care facilities because that was the only way the insurance was going to cover him going to an ED. And it turned out to be not a good outcome, from what I recall. And that's why this body said, no, we can't let that happen. And we'll protect the providers by making them. And then I'm not sure when the state came through saying everybody had to go to EDs, but that was what happened here. But that was early 90s from what I recall.
Yeah, it's all prior to the managed care bill of rights in New York State, before the prudent layperson and all the pre-authorization issues. It got into all of that, and they were a very they were probably the first more aggressive HMO in the region. And they were trying to manage care appropriately. I mean, that's what they were supposed to do. But anyway.
But that's what set off our region was saying, no, you have to go.
Well, I think the only other message that I would pass along to you guys is please make sure not to reinvent the wheel. Look at the projects that have done before. Talk to Dr. Shah from Monroe Livingston, who learned the lesson the hard way that you have to be very careful about how you structure these things. to make sure that you can actually end up with enough included patients, because they excluded so many. And I would also look to some of the papers that have been written to say that it's very difficult for EMS providers to triage people to alternative destinations without having a bunch of disasters. So while I think this is something that should be looked at again, and I think we should give it a chance, I would say go forth carefully. Go forth carefully. We no longer have a quorum, but I don't think this is an actionable item.
You do by video.
We have Rob, we have Bruce. You on the line still?
Yes, I am.
Oh, there you are. Thank you. So actually,
here.
We do have a quorum. So I made the motion that we should support this and look forward to seeing more. Do I have a second? I have several seconds. All in favor of? Excellent. Dan, keep us posted.
Oh, I sit behind you too.
Oh, thank you, Rob. Sorry about that.
Don, did you vote for John?
Oh, yes, actually, my vote counts for two. That's an John.
That's true.
He may not be too happy as an urgent care.
No, he will. He's going to get the patients. On the other hand, he may not get paid for them. All right. So, does anybody have any other items from the floor? Dan, thank you for bringing that up. All right. Seeing none, I'd like the physicians to reconvene in a conference room in the back. So we're going to have a quick executive session. And everybody else, thank you very much.
Dr. McHugh, I just need your cell phone number. If you could type that in for me.
Actually, maybe see if I can just switch over.
No, I'm going to have to call you by phone. I have to get out of the system.
Adjourn to an executive session.
Mike, you may want to mention no meeting next January.
What?
No meeting in
Oh,
January.
no meeting in January, guys.
Do you have a cell? Dr. Daly or Dr. McHugh, I'm going to call you on your cell phone in a couple minutes. Dr. Ushkow, the same thing for you. Oh, I'll call you. Thank you.
Okay, so you want me to hang up then?
Yep, you can hang up.
All right.